Good afternoon, everyone. Thank you so much for joining another one of our live Q&A sessions. We're very grateful to be able to have Dr Arvind Kaul answering your questions that you've been sending in this afternoon. If you haven't yet had the chance to do so, then don't worry, we will be taking questions live during the course of this video. So if you just do want to comment any questions you might have left in the comments section down below, we're going to be trying to get through as many of them as possible, and we've got about an hour today that we're going to be dedicating to answering your questions. So as I said, if you do have any you've not already sent in, then please do let us know and we'll try to get through as many as possible. We've got some very exciting things lined up for GHIC for the rest of the year, so be sure to keep an eye on our social media for that. If you're not already, then do sign up to our newsletter as well and be staying on top of regular updates. And of course, if you are at all possible able to, then please do donate to GHIC. You can do that over on the website if you click the donate button. And we don't receive any government funding as a charity, so it's only through your generous donations that we are able to do Q&A videos like these and provide support to patients that is so needed for people with APS. So as I said, if it's all possible, then please do make a donation. We're so grateful for all the support from everyone for the charity. So yeah, thank you very much for people who have already donated. As I said, we're delighted today to be joined by Dr. Arvind Kaul. So thank you so much, Arvind, for joining us today and giving up your time to answer these questions.
You're welcome. Thank you very much for the introduction, Charlene.
That's quite all right. Great to have you. As I said, we've had quite a few sent in, so I think we'll start off with some COVID questions and kind of get those ones out of the way. Obviously, there's been some news recently around booster vaccines and things, so people have just sent in some questions, mostly around vaccines, just for some clarifications. So we'll start off with those. Comment has come in from Suzanne. She said, my question is, I work at my local NHS hospital in Norfolk, and they've just started booking staff in for their booster COVID jab, as long as it is at least 26 weeks after the second jab. She said, I will be able to book my booster jab on or after the 26th of November, but as I have APS and I've had the AstraZeneca vaccination, I've been told I will have my booster jab and then we'll need a fourth injection a few weeks after that. Do you know if that's correct at all? Is there expected to be a kind of another vaccine after the third one for people who are getting boosters?
Oh, that's a difficult one, really. I haven't come across that. As far as I'm aware, the so-called booster, which they're not really calling a booster, they're calling the third primary vaccination, is the only one that's available at the moment, and that's primarily for those patients at risk. So I haven't heard about a fourth one, so that's news to me, and it's certainly not something that we're throwing out as an option, having a fourth vaccination. So much of the data that we've got is really from the Pfizer Moderna vaccinations, but we also know that mixing vaccines shouldn't be a big issue either. So it shouldn't really matter whether you've had the AstraZeneca or the Pfizer or the Moderna vaccines, you'll get a third vaccine. And as I've said, we've not been informed about a fourth one. So I'm not really sure where that information is coming out from. So I can't comment on any specific cases, obviously.
Okay, yeah, no, of course. Maybe best to try get a bit more information on that and speak
Yeah,
to a medical
locally.
professional if possible. That she's kind of given a second part to the question, and said that she's just about to start her new biological drug, which is being delivered next week. And she just wants to know, are boosters, to your knowledge, safe with biologics? And she's just quite concerned about the possible interactions, any side effects. Do you know anything about that?
Yes, we're not really worried about the interactions really, and there haven't been many reports of any severe interactions with drugs that we use commonly for autoimmune conditions. So I'd like to reassure Suzanne that really there shouldn't be an issue with interactions. Side effects occur with any vaccine, and certainly whilst the data for Hughes syndrome and antiphospholipid syndrome is not really fully formed yet, certainly for lupus patients, the vaccines are provided not only from a large study that was published, but also from our personal experience, haven't really caused any significant problems. Flare-ups of conditions like lupus are not that common after vaccination, so we wouldn't anticipate that the vaccine would cause a significant interaction. Where the problem lies is really the degree of immune suppression, and this is where, or the reason why booster vaccines or third primary vaccines are thought to be necessary, and that's because people who are immunosuppressed may not produce such a good response to the vaccine. And that's so for all vaccines. And we think that the data thus far, there's a big study called the Octave study done out of Glasgow and Birmingham, which suggested that whilst healthy controls have a pretty much 100% production of antibodies, in other words, 100% of patients produce antibodies if you're healthy and not immunocompromised, immunocompromised patients who are on immune suppressing drugs, about 89% produce antibodies and of variable levels. Most people have a very good response. And as I say, the data is mainly for the Pfizer vaccine. Good response after the first dose, it's fairly minimal, but after the second one, it's actually pretty effective. Where the problem lies is that in about 40% of immunocompromised patients don't have enough of a response. They may not produce enough antibodies or a very low level of antibodies. And this is why the booster or the third primary vaccine is being rolled out to immunocompromised patients first. And that could be a wide range of people on immunosuppressive drugs, but also patients with cancers, chemotherapy patients. And this is a wide range of rheumatological conditions, including rheumatoid arthritis, psoriatic arthritis, and will include lupus, although the study itself didn't specifically look at lupus. Vasculitis was also included. So immunosuppression may in some patients, certainly not the majority, probably the minority of patients, mean that your vaccine response is not quite as good as it should be. And that's why the booster is being rolled out. It's easier to give the booster to everyone than measure antibody levels. And the other thing that's really important to mention with immunosuppression is antibody levels per se may not be the only determinant of your response to coronavirus. There may be other factors which include certain cell responses, the T cells particularly, which may also be important. And so just measuring antibodies may not give the full picture as to whether somebody is fully protected or not. So you can tell from that it's really still quite a fluid situation in terms of who can be protected on immunosuppression, who isn't. The best advice we can give right now is don't worry too much about the immunosuppression. Make sure you have the 3 vaccines and get as much protected as you can.
Yeah, okay, thank you very much. I think that's very sound advice there. And she did finish off by saying thank you so much for giving up your time to us today to do this talk, and that she's made a donation to GHIC. Thank you so much, Suzanne. That's extremely appreciated.
Yeah, absolutely. I could just second that as well. Thank you very much. And we're grateful to everyone really for giving up their time too to listen. Thank you, yeah. And to donate.
That's great. Thank you so much. Just following on from that discussion then about kind of level of protection with the COVID vaccine, etc. We've had a question come in from Sanjita who just wants some clarification around whether the vaccine could trigger an immune system stimulation and lead to more inflammation and worsen APS symptoms. I think we've spoken about this before in a previous video, but just to reiterate, is there any kind of danger of that happening?
So the data is now sort of slowly trickling out, and certainly from the data that I've seen, and our personal experience here has also been very positive with vaccines. None of the vaccines really have shown any significant problem with flare-ups. And the data on a large study done recently, specifically in lupus patients, suggested that maybe about 2 or 3% of patients may flare up with some of their symptoms, predominantly musculoskeletal symptoms with their lupus. But that tells you that the vast majority of patients are not going to flare on vaccination. So the key thing is to not worry too much about flare-ups with COVID vaccinations. Flare-ups can occur with many, many vaccines, and they can occur with patients who have no specific immune condition, feeling achy, feeling a bit stiff and sore a few days, sometimes a week or 10 days after a vaccine is not that uncommon. And my advice is not to worry that your lupus may be at risk or at risk of getting worse with vaccines, because the data and our personal experience really doesn't point towards it. And indeed, we've had very, very few patients complaining of flare-ups after vaccination. Even after coronavirus infection, our experiences has been quite positive, and we've not found many people have actually even had the coronavirus, and secondly had it in such a severe way that they had to be hospitalized. Most patients with lupus in immune suppressed states because of medications actually have done rather well. And so my advice is do not worry. The vaccination is going to be far less risk than the virus itself.
Okay, that's great, and really reassuring that has been kind of feedback so far from your side. The last COVID question then, it's coming from a lady called Helen. She has actually had COVID herself. So she said that she was diagnosed with lupus 5 years ago, and then APS was diagnosed about 3 years ago. She does take Warfarin, and she said her INR is always very difficult to control, but her ideal range is 2.5. And she just said that recently she's had a hospital stay, and since being home, her INR has been anything from 1 to 7.7. She's had 2 major bleeds and needed vitamin K. She just wanted to know, do you think that there's any possibility that having COVID could have massively affected her INR and made her APS quite unstable, or is it more likely that it could have been from her very serious lupus that was kind of flaring up prior to contracting COVID? Is there any suggestion it could be either of those two things?
That's a great question, and I think the answer lies in probably being unwell rather than COVID specifically. When you're in hospital, if you're unwell, you're given lots of new drugs, different drugs. It may be antibiotics, for example. There may be lots of interactions with warfarin, which wouldn't be unusual. And being unwell also alters your metabolism of warfarin from the liver and other organs, affects your absorption of the drug. So there are many variables, and being in hospital, your diet will also change. And of course, as we know, diet, particularly vitamin K containing foods, will affect warfarin metabolism as well. So all of these factors are likely to be far greater influence than coronavirus. And whilst we know coronavirus does cause thrombosis, and it can, under certain circumstances, induce antiphospholipid antibodies, there may be many other reasons which are not unusual in themselves why the INR has varied. Going back to coronavirus, could the antiphospholipid antibodies have increased, and therefore that's affected the warfarin? To an extent, possibly. That certainly could be the case, but it's not likely to be anything other than a transient phenomenon. So we wouldn't expect this kind of lability with the INR to be anything other than transient. And firstly, I'd like to wish her well and hope she gets better soon. But once she's in a stable environment and eating stable diet, without any new drugs, without antibiotics, I would expect everything really to go back to where it was, hopefully much more stable than she's experiencing now.
Okay, great. Thank you very much. Leading on then from the COVID questions, we're going to be discussing some more general APS questions now. So touching on the conversation we've just been having about warfarin and INR, we've had some more questions sent in around that topic. So we've had a question come in that is asking about the reliability of finger prick tests to be able to measure INR. This person has had kind of mixed feedback saying that it's not as accurate as it should be. What's your advice, and do you suggest that people do use that method to kind of effectively manage their INR level?
If you're talking about the home testing kits, I guess, they've had a little bit of varied good, bad publicity. The advantages of them really are that you can monitor your INR at home. The disadvantage is they do need to be very accurately calibrated, and this is where the problem has lain, really, that the calibration can be a little bit off, and that can affect the measurements. As a guide to general trends in the INR, they're probably reasonably accurate. I would always say that this kind of home measurement should be done with the full collaboration of the anticoagulation clinic that you're visiting, because they will also be able to check the calibration of the machine that you're using. I would never say use the machine on its own in isolation to monitor your INR, because these kind of machines can be prone to error. Now, does that mean you shouldn't get a machine? And the answer to that is no. I think it's a reasonable thing, but do it in collaboration with your anticoagulation clinic. Don't do it in isolation, because these machines can be variable and they can be slightly inaccurate, and that can give misleading information. In addition, you need to be able to interpret the INR and what to do about it. And self-medicating like this with a very potent drug like warfarin, which really requires a very high level of knowledge, shouldn't be done without the anticoagulation clinic. So yeah, by all means use them in conjunction with the anticoagulation clinics, with a full knowledge of the anticoagulation clinic, so that you can be monitored safely and effectively. Don't do it in isolation.
Okay, great. Thank you for clarifying on that one, Arvind. And just one more question then around warfarin and INR. We've had the question sent in from Lee, who said, I'm newly diagnosed with triple positive APS following a stroke and being treated with warfarin, but my INR levels aren't stabilizing since November, so weekly checks and changes to medication are happening. Is this usual and something I need to get used to, or should I request a review with a rheumatologist? And then they also just say that fatigue is an issue because of the erratic way levels go too high and then too low. So yeah, do you think that's usual? Would it usually take that long for INR levels to become stable, or should they be having that conversation with a rheumatologist?
So it's actually probably more unusual for them to be very stable. I always get get a smile on my face when I see a very stable INR with an antiphospholipid Hugh syndrome patient. So it's very common to get these very erratic INRs. And the reason isn't entirely clear, and it may be due, particularly if Lee is triple positive, for example, to variable antibody levels affecting the coagulation system. But there are many other factors which could be modifiable. Making sure you take the warfarin exactly the same time every day, for example, making sure that you have a stable level of vitamin K containing foods. But it is one of the issues that we commonly find with antiphospholipid syndrome, the erratic nature of the INR. And the symptoms that you've mentioned are very common in patients with Hughes syndrome, and fatigue and tiredness are very common. Aches and pains are very common. And we know headaches occur, and they can often be a clue to the INR itself. And we have patients that tell us that their confusion, their word finding difficulties all increase if their INR falls below a certain threshold, usually quite high, usually around 3.5 to 4. And if it's below that, they can instantly tell their INR is low. So this isn't unusual to get the erratic INR. I would probably wholesale just look at lifestyle, look at the way you're taking the medication, the foods you're eating. All of these may impact on the INR, and it may be difficult to actually get right. This is one of the areas where home monitoring can be quite important and useful when you've got an erratic INR, because you want to know the day-to-day fluctuations, not the week-to-week ones. And so home monitoring for somebody like yourself, Lee, might be a good option, again, in conjunction with your anticoagulation clinic. And it also is one of the reasons why all of us as rheumatologists and hematologists really wish INR would go away and we could replace it with one of the newer anticoagulants that don't need the monitoring. Warfarin is an older drug, but it's still very much in 2021 the gold standard for Hughes syndrome treatment. And that requires a lot of patience, a lot of monitoring, a lot of lifestyle change. And wouldn't it be lovely if we could just get a drug that actually you didn't need that monitoring for? And that was the purpose of the very new anticoagulants, the so-called DOACs. But the problem has been that the risk to Hughes syndrome patients is probably a little bit higher with these newer drugs of rethrombosis, of getting a new stroke, a new heart attack, a new blood clot compared to Warfarin. So that's why they're not yet recommended. Again, they were recommended and they're now being removed from that recommendation with Hughes syndrome patients. But your question really goes to the heart of why we would like a replacement for Warfarin. Wouldn't it be lovely if we had a replacement? But your experience, Lee, I can assure you, is not unusual. And it almost certainly is not really what you're doing. Although, as I say, look at what you're doing, make sure you're doing everything the right way. It's more a function of antibody levels, dietary changes, and the way the antiphospholipid syndrome behaves, really, unfortunately. But do whatever you can in your lifestyle, modify your diet, make sure you have a stable environment with your diet around the time of the Warfarin. Take it at the same time every day, and home monitoring may allow you some fine tuning, but only in conjunction with your anticoagulation clinic.
Okay, great.
I think you had a second bit of the question, sorry, before I forget. I think the musculoskeletal symptoms, should you be referred to a rheumatologist with that variable INR? That would be a reasonable option if you're not already seeing one. Hematologists are obviously very adept at monitoring the INR and trying to get that right. For the other symptoms that you've got, Lee, including musculoskeletal symptoms, I'm not sure whether you're on hydroxychloroquine. Hydroxychloroquine is a drug which we use for antiphospholipid Hughes syndrome. For some of the other symptoms, including brain fog issues, including aches, pains, including fatigue and tiredness. The hematologist probably won't prescribe you that. They're not au fait with the drug. But it may also add a little bit of value to some of the other symptoms that you've got. And the rheumatologists really will be the right people to see to treat those kind of symptoms.
Okay, great. Thank you very much. So just drawing on what you were saying then, kind of talking more about some different drugs that are being used at the moment. Sarah sent in a question and said, what are your thoughts on treating single positive with Rivaroxaban? There's been a lot of negativity around this drug in the APS community, but it's so easy to take and so far it's working well for me.
Yes, completely get that. The few studies that have been done so far suggest that the high-risk patients, triple positive particularly, have rethrombosis at a higher rate with Rivaroxaban and similar drugs compared to Warfarin. And a study that was published about a couple of years ago now by Vittoria Pengo suggested that warfarin was probably better in controlling APS rethrombosis rate compared to the newer drugs. That's why the European Medicines Agency took or did not recommend the newer anticoagulants for antiphospholipid Hughes syndrome. Now, you're talking about single positive, double positive, triple positive. You're at risk if you're single positive. Your risk just seems to be higher with rethrombosis with triple positive. Should we be using it in single positive patients, Rivaroxaban and similar drugs? At the moment, really sort of the theme around antiphospholipid syndrome is still warfarin is the go-to drug. Now, my colleagues and I, through another clinical study, are going to look at whether single positive patients have benefit with Rivaroxaban compared to warfarin. That study is in the pipeline, but there's no doubt that whilst rethrombosis occurs with Rivaroxaban in the studies, there'll be many people where actually it will work very well. Remember, clinical trials look at overall pictures. They don't pick out individual patients, and the overall picture was one of rethrombosis. But underlying that, there will be many patients who will benefit from Rivaroxaban and may never get a rethrombosis, perhaps the lower risk. So if you're doing very well on Rivaroxaban, touch wood, that will continue. And it's the same logic by which we say, well, if you've got antiphospholipid antibodies and you've never had thrombosis, your risk is going to be there, but it's not going to be 100%. And most patients with antiphospholipid antibodies do not ever get thrombosis. So the same argument applies that most people on Rivaroxaban and who are already on it and have been on it prior to the European Medicines Agency guidance, and they're continuing on it, may still not be at high risk, and they probably will be pretty safe to continue Rivaroxaban. So these are difficult issues which we haven't yet worked through fully, but if you're doing well on Rivaroxaban, single positive, no recurrence, then that's great, continue, but just be mindful that those kind of studies haven't yet been fully done in that group of patients, and that's something that we're doing as we speak in a current clinical trial.
Okay, great. That's fantastic. Just switching to a few comments that we've got that's come in on the live stream. We've actually had a comment back from Helen, the lady who wrote in about saying that she contracted COVID and was speaking about her INR. She said, "Thank you so much for answering my question. I'm home from hospital now. It was very scary at times, as on high dependency ward. Her INR is still unstable, but she's getting there. Stats are still dropping and recovering at home. Thank you again." So thank you so much, Helen. Great to have you join in with the Q&A video today. We've also had a question that's come in live from Tamara. So thank you so much for watching, Tamara. She said, "Thank you so much for your time. I've been injecting Fondaparinux for 10 plus years and take baby aspirin. I'm triple positive and still clot. On top of APS, I have severe Crohn's disease as well as Sjögren's. And I have a duodenostomy due to Crohn's with only a small amount of bowel left. I previously haven't been able to absorb oral medications. Am I destined to inject forever, or is there something that may be suitable on the horizon?" She said she also suffers with considerable muscular and joint pain. Is there something that can assist with that that is non-addictive?
Okay, so yes, I mean, obviously, good luck with all your medical conditions, but it's a difficult issue. You would have been put on Fondaparinux by the haematologist, and clearly they felt that that was the best fit for you. And these decisions are sometimes really very hard to fathom. But Fondaparinux is a good agent. I think mentioned also injecting heparin. Is that right?
She just said that she takes baby aspirin.
Baby aspirin and Fondaparinux.
Yeah.
Okay, but still clotting. So those decisions need to be made really by the haematologist, and the level of risk will vary from person to person depending on their medical profile. But other conditions like inflammatory bowel disease will also potentially increase your risk of blood clotting. If you're rethrombosing, then in general, the options would include heparin injections. We don't tend to give those long term because they can cause other side effects unless there's no option. And those side effects include things like osteoporosis, low platelet counts, for example, and heparin, whilst it is reversible, if it does cause bleeding, the low molecular weight heparin, which you standard use once or twice a day, can be a little bit more difficult to reverse quickly. So reversal becomes an issue if you do bleed. And so heparin is an option. Then you've got other options which include the newer drugs, the Rivaroxaban, for example, dagibatran, for example, edoxaban. All of these are newer anticoagulants. Then you have Warfarin. And so the choice is not huge as to what is likely to be safe for you. Clearly, your risk assessment, I guess, from the haematologist, obviously I can't comment on individual cases, would have suggested, and we don't know whether you've been on any of the other drugs, but may have suggested that fondaparinux would be a good option for you, and it is a good anticoagulant. So if you rethrombose, as I say, those are generally the options. For other symptoms, again, I'm a great fan of drugs like hydroxychloroquine, and we use hydroxychloroquine for many of our patients with lupus, for example, and Hughes antiphospholipid syndrome. And we use that because it can be very effective at helping not only the stickiness of the blood, it is itself a very, very slight, mild anticoagulant, hydroxychloroquine, but it also helps with other symptoms, which include joint pains, can include things like fatigue, tiredness, the cognitive issues that occur with antiphospholipid syndrome. So hydroxychloroquine may be a good drug to add in. It isn't addictive. People worry about the eye problems, and that is an issue with the eyes historically. And in years gone by, hydroxychloroquine was used at a much higher dose, and it can cause eye problems, damage to the back of the eye. Nowadays, we're much more adept at fine-tuning the dose. We don't give high doses, and the rate of eye problems with hydroxychloroquine, which you'll read about, is very low indeed. And in my practice, I've not had a single case of eye problems with hydroxychloroquine in the last 10 years. So it's a very safe drug, very useful to add a little bit of blood thinning to the antiphospholipid syndrome patients who reclot, and will be a useful drug for you if you're having rethrombosis. If any of the other options I mentioned, the newer anticoagulants, heparin, warfarin, are not available to you or are not felt to be appropriate.
Okay, thank you very much for answering that one. So we've also had some more questions come in around symptoms, side effects, and whether certain things are related to APS or not. So we'll just go through a few of those. Nikki sent in a question saying, what is the incidence and presentation of anemia in APS?
Okay, so anemia per se, on its own as a sign of APS, usually indicates possible bleeding. So it's not necessarily a great sign of APS on its own. And anemia does occur, but it occurs with a wide range of conditions. And it's not as common in APS, in my experience, as it is with other conditions which overlap or are also happening at the same time. For example, patients with APS often have lupus. And lupus, well recognized to cause anemia. It causes bone marrow changes. It's not uncommon, and it does happen occasionally with APS. More commonly it occurs with an underlying condition. And the other circumstance in which anemia will occur with APS is if you bleed. So if patients are on warfarin, for example, and they have a bleeding episode, in other words, they bleed either under the skin, or if they bleed from the nose, or if they have a gastrointestinal bleed, then the hemoglobin will go down. And just to clarify, anemia, for those of you who may not know, is really a low hemoglobin or blood count. It's the red stuff in your blood that is lost, and that's often iron dependent. but it's also dependent on other things like drugs, which can cause anemia through bleeding or directly through the bone marrow. And many of these drugs are used in lupus, rheumatoid arthritis, and some are also used in Hughes antiphospholipid syndrome. As a primary event, it's not as common as we see in lupus and other conditions. As a secondary event, it occurs when there's bleeding or when there are certain drugs used that suppress the bone marrow. So yes, it occurs. Your doctor, family doctor, can check for that, and they will check iron levels as well, and also to check other things like vitamin B12, low levels of which are common in autoimmune conditions, including Hughes syndrome. And so get your GP to check iron, vitamin B12, the other things that cause anemia, which are co-expressed, if you like, with Hughes syndrome, are things like thyroid dysfunction, so low levels of thyroid hormone, commonly found in autoimmune conditions, including Hughes. So all of these tests need to be done through your GP and should be done as a routine screening if you're anemic.
Okay, great. Thank you for answering that one. Another one that come in has said, can APS cause persistent swollen lymph nodes?
Okay, good question. Short answer is it can. We don't find it that often in what's called primary Hughes syndrome, where it occurs on its own. Again, secondary Hughes syndrome with conditions like lupus does quite commonly cause swollen glands. And so swollen glands, to answer the question, yes, can occur with Hughes syndrome on its own, but it's not as common as we find it in other conditions like lupus with Hughes syndrome. And it's often confused for cancer, for example. It's confused for specifically for a condition called lymphoma, but very, very rarely is it due to that. And so if anybody feels they've been told they've got lymph glands, just be reassured that the vast majority of people, and I mean the vast majority, over 99% really, have swollen glands due to an immune condition, not due to cancer or anything else.
Okay, thank you for that one. And another one that's come in, quite a short one as well, is what does it mean when your ANA pattern changes from homogeneous to cytoplasmic?
Okay, so these different patterns of ANA are seen by the lab, and they're seen because they stain cell lines, usually something called HEP2 cells, with a stain that detects ANA. So they can then, under the microscope, see a pattern of the antibodies which have stuck to the cell in areas where the ANA is expressed, or where the nuclear antigens, rather, that the antibody suggests are, sorry, I'm just going to call, I'm just going to have to,
Okay, Arvind will be joining us back in just a moment, but just to say thank you so much to everyone who has been sending in your questions today and watching us live. We really do appreciate it, and we're grateful to everyone that has been supporting the charity so far. For those of you who missed the start of the video, I was explaining to everyone that we've got some really great plans coming up for GHIC later on in the year, so that'll be fantastic. So yeah, do keep an eye on all our social media and things for plans coming up later on in the year. Make sure you're subscribed to our mailing list, and of course donate if you can. So I think we are going to be joined back by Arvind now. So yes, he is back here, no problem. So we were discussing about the ANA patterns.
Yes.
That question.
Yeah, so I hope you got the first bit, which is that you'll see staining under the microscope, or the lab sees that. The various patterns sometimes denote where the antibody is. So cytoplasmic pattern often would dictate something called a Rho antibody, whereas a nuclear pattern will suggest double-stranded DNA and other antibodies. Does it matter? The short answer is not really. Don't look at the staining pattern particularly as the key element of your disease. It isn't. The key element of anybody's condition is really the symptoms that they have. And so the pattern of staining is not of great relevance to the grand scheme of things. It doesn't dictate how we treat the condition. It doesn't say to us that we need to change the treatment. What dictates all of that really are primarily your symptoms and the effect that the medications that you're already on may have had or not had. So the staining pattern is not important. So don't worry about it primarily, and it doesn't make much difference, or just make any difference really to the treatment. Your symptoms actually trump all of the staining patterns that we see.
Okay, great. Thank you for answering that one. I'd just like to read a nice comment that's come in from Vicky, who's watching us live. Thank you for joining us, Vicky. She said, I'm triple positive APS. She's treated at St Thomas's in London. She had a stroke at age 24, which caused a lot of damage. And she just wanted to basically talk to us about her experience and say that she's had the most fantastic care. She is on Warfarin as well, and she's had venous tested only as triple positive. She said she'd rather be 100% covered than use the newer medications, and always happy to have medical students in her appointments, and that St Thomas has given her amazing care so far. So great to hear that you've had such a positive experience.
That's fantastic.
Vicky.
That's really good news. Yeah, I'm glad. And thank you so much for training the next generation of doctors, because your knowledge about Hughes syndrome is very variable amongst the medical community. And so training the future doctors that are going to look after you, I think, is really important. So thank you so much for giving your time and your patience, to train the next generation of doctors. So thank you for all the kind comments as well.
Yeah, no, that's fantastic. Just going back to some of the questions that have been coming in live. One from Rachel, so kind of already know the answer to this one, but it would be good to get your input as well. Rachel said that she was diagnosed 15 years ago with APS after 7 miscarriages. I'm so sorry to hear that, Rachel. Unfortunately, she had no follow-up advice or support. She says, I suffer with fatigue, joint pains, headaches, brain fog, forgetfulness. Are these symptoms all related?
There's 2 letters to the answer, or 3 letters to the answer. Is that yes, definitely all related. So a lot of patients do have very similar symptoms. And if you've already got the diagnosis of APS, remember APS is not just about thrombosis. It is an immune condition, and in common with all other immune conditions will have a variety of symptoms, which include joint pains, which include skin rashes, will include fatigue and tiredness, and often the fatigue and tiredness is the most debilitating aspect of the condition. And it's also important to remember that fatigue and tiredness and the cognitive issues that go with Hughes syndrome are multidimensional in nature. There's good evidence from many other conditions, including lupus, for example, multiple sclerosis, rheumatoid arthritis, that fatigue is really influenced by many life factors as well. And I often tell patients, remember your life is not the same as it was. You're having to get up every morning, think about taking a medication, alter your lifestyle, make sure that factors such as relationships, pregnancies, all the simple things, for example, that many patients would take, or many people would take for granted, patients with Hughes syndrome can't take for granted. And if you imagine the brain as several boxes, which are kind of mildly interconnected, the fatigue center is one of them, tells you to go to sleep at nighttime, then reactivates and tells you to get up. That center, for example, is lightly connected to other centers. But with these conditions, these little boxes of the brain that control different centers, the way I look at it is they actually interconnect in a much more sharp way. And they start talking to each other in ways that they didn't talk to each other beforehand. And so things like anxiety, which everybody gets to a greater or lesser degree, then filter into this fatigue center, and that filters into other centers, including those controlling low mood, muscle, joints, etc. So you can see the brain is an incredibly powerful organ, interconnected, and these kind of symptoms are not just monodimensional. It's not just because you've got Hughes syndrome, it's because your life has been changed by this condition. relationships have been changed by this condition, financial implications, job implications. None of these are really things that we can see in people, but they are things that really affect people and cause your symptoms to be a lot worse than they would be if these conditions had no impact on you. So there are multiple symptoms that occur with Hughes syndrome. All of the ones that you've described really are part and parcel. And remember, many people will get other features, low platelet counts, for example. Some people will get problems with the heart valves. And so there are medical conditions which are associated strongly with Hughes syndrome, many of which you've already alluded to. These are not unusual.
Okay, thank you for that. And I think it's really interesting there that you pointed out all the other kind of side effects that people can have as a result of having Hughes syndrome, you know, how it affects so many different parts of one's life. And it's not just those physical symptoms that come into play. It's a whole wide variety of other things, which is why it's so important that APS patients are getting the right support that they need. And so we're kind of coming towards the end of our video. We've got a few more questions left. So one that's come through from Jane, she said that she was diagnosed 28 years ago after a stillbirth and also previously had placenta abruption. They didn't do blood tests then, and recently she had 3 APS tests which were all negative. Do you know why that is? Even though she had the diagnosis so long ago, her tests are all now coming up negative?
Really not unusual, and the context I think is important. So antibody tests wax and wane all the time, and the reason is unclear. And in general, you know, for other conditions, you might infer that having negative tests might be a good thing. For antiphospholipid syndrome, those people who've had thrombosis or blood clots already and are on warfarin, for example, sometimes their tests, having been very strongly positive, go negative. Can we infer from that their risk is therefore zero and they can stop warfarin? The answer seems to be no. And so the levels of antibodies that we detect may not be a good guide as to your level of risk. Now, if you've had obstetric antiphospholipid syndrome only and no other thrombosis, it may not be an issue if you're not planning to have more pregnancies. But if you've already had a blood clot and you're on warfarin and your levels of antibodies go to zero, unfortunately, it doesn't mean to say that you can stop your anticoagulation. You will still need to continue it because your level of risk is still likely to be higher than background.
Okay, great. Thank you for answering that one. So we've had another live comment from Rhiannon. Thank you so much for tuning in today, Rhiannon. It's really appreciated. And she said, are there any links that you know of between APS and photophobia? I'm finding that bright flashing lights appear to make my dizziness, headaches, fatigue worse. If so, is there anything that she can do for this, such as glasses, etc.? Is that something that you've come across before?
Photophobia is not uncommon in a lot of autoimmune conditions. Particularly we see it in conditions like lupus, not so much in antiphospholipid syndrome. So it's a difficult circumstance because photophobia effectively is just sunlight sensitivity. Your eyes find it difficult to accommodate quickly enough to the bright light. It may be a normal variant. It doesn't necessarily mean to say it's a disease variant. To try and control it, I think things like glasses, avoiding bright or direct sunlight are probably going to be the easiest way of trying to control that. It's not something that we would normally give medications for. If you feel your eyesight is affected, it's definitely worth then going to see an eye doctor to get a detailed look at the back of your eyes. An optician in the first instance will be reasonable just to test your eyes. Treating it is a little bit more difficult. There isn't any standard treatment that we give, except to say that the underlying condition should be as stable as possible and as well treated as possible. It's rarely a problem, though, that most people need a specific treatment for. And it's rarely a problem that we find there's an eye problem. But it clearly represents a degree of hyperreactivity to light with your eyes. And I think just rather than over-medicating or trying different medications, it's probably a good idea just to avoid direct sunlight, wear dark-rimmed glasses, for example, and that will probably be the best option. I think it's a difficult issue and no real answer to what you should do.
Okay, thanks very much though. And kind of just as we said, coming towards the end of our Q&A session, I think this would be quite an interesting one to kind of finish up on. And as we said, any questions that we haven't been able to get through today, we are going to be doing more of these Q&As in the future. So we'll keep the questions back for next time. And if you have any that come up before then, please do always just send them in. You can find our contact details on our website if you do want to send us an email about anything, and we'll try to support you as best we can. So going on to the final question then is from Deborah, who said that I tend to find rheumatologists aren't that focused on APS compared to other autoimmune diseases, and she's given the example of lupus. Why do you think that is, and how can we bring it to the forefront of their attention moving forward?
Yeah, that's a really good question. And I think, you know, from our lady earlier on, sorry, I forget her name, but who was at St Thomas's with triple positive Hughes syndrome, it is really about educating the medical fraternity at large, really, just to make sure that they understand what patients' needs are. And I think much of it really is also about being patient-focused as a doctor. There's a more generic element to how doctors should approach patients, and that is really listening. You know, the art of listening in busy clinical environments, it's easy to forget that's a skill that needs to be ingrained in all doctors and indeed in all healthcare professionals. So the answer to the question is really, firstly, generic, that actually training of doctors from an early age needs to be patient-focused, needs to be able to listen to patients and have the patience to listen to patients, because patients need to be able to express themselves in ways that they feel comfortable doing. And so that also takes time. So to be given the time and the space to do that for patients is really important from doctors. So that's a generic answer. The more specific answer would be to disseminate as much information as we can. And part of that is through charities like GHIC. Part of that is really through your interactions with GHIC. And we have to go back to donating, because through your donations, we can then put out calls for more research. We can give funding for doctors to attend courses on Hughes syndrome, and that increases the level of knowledge generally about antiphospholipid syndrome. And I completely get where you're coming from. Part of the issue, I guess, is also because it's, to an extent, it's a shared condition with hematology. We don't start the anticoagulation, the hematologist does. My view on Hughes, however, is that hematologists often like taking the lead from us as to what is the most appropriate anticoagulation. So it does also mean that rheumatologists need to be very clued up about the current status of newer anticoagulants and the options available, because whilst hematologists are excellent at what they do, quite often they may not know about other drugs like hydroxychloroquine and other immune suppressing drugs. And so they often will defer to rheumatologists for more fine tuning of the care and perhaps a little bit of guidance about what is the best anticoagulation to use. So always have a rheumatologist, is my view, with antiphospholipid syndrome. You should always have a rheumatologist that you can go to for guidance. I'm sorry that the experience hasn't been so good for the person who asked the question, but as I say, that's a generic skill. You need to find a rheumatologist who listens, who takes the time to listen and understand your concerns. And that is, unfortunately, a people issue. You'll come across different strands of thought about people. You know, you come across people who are good, who are kind, considerate, and people who are not so kind and considerate. And unfortunately, doctors are people, and you'll come across exactly the same variation in your practice. And if you're not happy with a particular rheumatologist, if you can change, just ask to change. Don't be frightened about doing that. If there's another rheumatologist that you might feel more comfortable with, then do that. Don't feel uncomfortable. You know, there is no black book that we circulate around saying this patient asked for a different rheumatologist. This is supposed to be a patient-focused service, the NHS, and indeed any medical service, and that's really what it should reflect. So I wish you well.
Okay, great. Thank you so much, Arvind. That brings us to the end of the Q&A video for today. But as I said, we will be doing more in the future, and we'll be holding back questions that we've not been able to answer this time. So hopefully we'll be able to get round to answering your question next time. Thank you so much to everyone who tuned in and sent your questions. We've also been having lots of lovely messages come in of thanks. So thank you so much, Arvind, for giving up your time today and answering these much needed questions. As Arvind mentioned, of course, donations are absolutely vital for us to both progress work around APS, you know, invest in research, support people, and really progress things forward. So if you are able to, you can donate over on the GHIC website. And as I said, we're extremely grateful for any support. If you do want to do any fundraising for the charity, then do just get in touch as well. We'd be delighted to hear from you. But thank you so much to everyone who has joined in on this Q&A today, and we look forward to seeing you next time. Thanks very much.
Thank you. Thank you, Charlie.